Thank you. Assalamu alaikum and very good evening. I am Dr. Mahmoud Hassan Khan, Associate Consultant, Evercare Hospital, Dhaka, presenting a case in front of this learned and very august gathering. And my topic is all windows are not healthy window. I would like to convey my heartfelt gratitude to Professor Dr. BDECHO Reza sir for his continuous guidance. If we look through our window and see a bright sunny day, we are very much happy and very hopeful. But if we see a very rusty, very windy weather, that weather makes us depressed. So in a nutshell, weather matters. Our patient, 19 years old female without any significant comorbidities, admitted with the complaints of exertional shortness of breath and palpitation for last 6 months, lean and thin, mildly anemic, acyanotic, but with clapped fingers. First heart sound was normal, and pulmonary component of second heart sound is loud. Continuous murmur in the pulmonary area. ECG showed normal sinus rhythm, rate was around 100 beats per minute, regular, tall peak P wave indicating right atrial enlargement, small Q in one AVL, V5 and V6, and few non-specific STT changes were seen. Chest X-ray showed nothing significant but mild congestion. Then the echo showed dilated RA-RV, mild paradoxical septal motion, moderate tricuspid regurgitation, and dilated main pulmonary artery with its branches, and a very large window between aorta and main pulmonary artery with reversal of shunt. Moderate tear which showed severe pulmonary hypertension with pulmonary arterial systolic pressure around 86 millimeter of mercury. So in short, echo showed dilated RA-RV and main pulmonary artery with its branches, jerky and mildly paradoxical septal motion, fair LV systolic function with ejection fraction 55%, good RV systolic function, TAPC was 19 millimeter, a large approximately 23 millimeter aortopulmonary window with reversal of shunt, moderate tricuspid regurgitation, severe pulmonary hypertension with pulmonary arterial systolic pressure around 86 millimeter of mercury. So echocardiographic advice was cardiac cath to evaluate pulmonary vascular resistance and reversibility followed by possible surgical correction. Cardiac catheterization was done, which showed.
What was the PVRI?
PVR was, ma'am.
No, that's the most important to decide.
PVR was around 28 Woods unit before oxygen.
Okay.
And around 27 Wood units after 100% oxygen for 10 minutes. Predominant right to left shunt possible persisted both before and after oxygen. There was no reversibility of PVR observed after 100% oxygen for 10 minutes. LVgraphy, root aortography, and descending aortography were done. Root aortography showed a large aortopulmonary window through which contrast passing from aorta to pulmonary trunk. So in one sentence, a large AP window with no reversibility was seen. So I won't go in details about the AP window.
Don't want the theory part. Go to the what exactly you did.
Our take-home message from this interesting case was aortopulmonary window is a rare congenital heart disease. The possibility of surgical cure will be dependent on the age at operation and level of pulmonary vascular resistance.
Okay.
Aortopulmonary window can be confused with other defects. Clinical findings associated with an adequate echocardiogram can provide the information for the correct diagnosis. Sorry. Even though aortopulmonary septal defect is a rare anomaly, it should be considered whenever the course of complex congenital heart disease includes early cardiac failure, and pulmonary hypertension. Repair before 6 months will prevent irreversible damage of pulmonary vessels. So, thank you for your patience
Yeah,
hearing.
thank you. But what did you do to the patient?
The patient is on conservative management at the moment because
Okay.
surgeon refused to do any corrective surgery as because the PVR
Okay.
is.
So before the era of echocardiography, clinically it was impossible to distinguish between PDA and AP window. And they used to take for the PDA ligation and then close it and come back. The reason was AP window requires open heart surgery, PDA ligation is closed heart surgery. And that's how they used to come back. But today, echo is so excellent. I don't think any patient should go to the Eisenmengers like this. And when the PVRI is high, operating becomes very, very difficult.
Exactly.
Yeah, and if they are small, we can do the device closures I have done with excellent result. And you have to catch them when they are young rather than getting.
Yes, ma'am. But the patient came from a very rural area, and there was some familial constraints with the financial restrictions were there. So the patient was diagnosed late, and we had nothing to do except observing the patient.
Sorry, okay, thank you.
Thank you, ma'am.
Next person, please.